Good morning, everyone. Thanks, Muralidhar sir, for giving me this opportunity, as well as, and I'm very delighted to talk about echocardiography in VAD. And thanks everyone who have joined to attend this meeting today. I have no conflict of interest. I have I'll talk about LVAD mostly, but the scope of talk today is a pre-operative or pre-bypass assessment before LVAD surgery, immediate post-bypass T for LVAD flow optimization, role of echo in delayed complications, something about the RVAD and Impala devices, and few troubleshooting if we have time. My talk is based on these guidelines by the American Society of Echocardiography, which came in 2015. So many of my whatever I will speak today has been from this article. So this is the LVAD. This is the typical four-chamber view uh, with a patient with a LVAD. And the views of the echocardiography images may not be very great all the time with the patients with LVAD. These mechanical devices, a lot of artifacts. So many times you may not get very good images, but you will be able to see the cannula. You can see the cannula here in the four-chamber view, inflow cannula. And if you give color, there is a lot of flow aliasing, a lot of turbulence. And I have worked with third generation VAD, age VAD, which is a hardware VAD, and it gives a lot of color aliasing. And in 3D gives a slightly better image. You can see the cannula slightly better. Now coming to the pre-bypass examination for a patient who is going to have a LVAD. First and foremost thing, we need to see the RV function. For the RV function assessment, we can use the conventional parameters like fractional area change, TAPSE, and tissue Doppler like S prime and RV strain as well. And it's very important to compare the endostolic diameter of the RV to LV. If the RV to LV endostolic diameter is more than 0.72, few studies have shown that these patients are going to have RV dysfunction post-LVAD. And the tissue Doppler velocity, if less than 4.4, and if the free wall strain less than 14%, then there is prediction that post-operatively these patients will have significant RV dysfunction. And in most of the patients who is going to have LVAD, their fractional area change is around 20 to 30%. But those patients with FAC of less than 20%, they predict that post-operatively they may need a RVAD as well to support the RV. So prediction of the RVAD implant not only depends on the echo, but also if the patient has preoperative high bilirubin, altered liver function, or kidney function, these patients are more likely to get an RVAD along with LVAD for RV dysfunction. Degree of tear is very important in these cases. Usually it's a functional tear, and along with the tear, pulmonary artery systolic pressure should be measured all the time, because post-operatively with LVAD, the pulmonary artery systolic pressure should come down. And with the decrease in the PASP, the tear should ideally improve post-operatively. But the tear may be blunted pre-op if the right atrial pressure is very high. Other thing is that if the tricuspid annulus is more than 43 millimeter, there are different studies. They have shown that a tricuspid annulus more than 43 millimeter, you should always report to the surgeon, because this is the independent predictor of survival after LVAD. So what we do, if the patient has moderate to severe TR, definitely you should report to the surgeon. So should you do a ring annuloplasty or change the tricuspid valve? One of the studies have shown that in moderate to severe TR, if you do an annuloplasty or tricuspid surgery, then in the next 2 years after LVAD implant, the degree of TR is reduced. You should always search for the ASD or PFO very actively. And many a times it's very difficult to detect a small PF or ASD. So what you should do, you should use a Valsalva maneuver of 30 centimeter of water, and it should be agitated saline should be injected to a central vein, and once the RA gets opacified with agitated saline, you should release the Valsalva maneuver. Then you have to see whether the air bubbles have the agitated saline has reached the LA or not. This is a good way of looking at the ASD and PFO. And still, with all these measures, sometimes the ASD is masked. Still, we don't see the ASD or PFO, small ASD or PFO. Actually, it's there. So sometimes what the surgeons do, the surgeons clamp the pulmonary artery to raise the RA pressure and see if there is a PF or not. And clot in the LAA. So any thrombus or any clot in the heart is not an absolute contraindication. It's not. So you should always report to the surgeon, and if the surgeon should take out these clots carefully. Otherwise, this thrombus can cause occlusion of the LVAD inflow cannula and outflow cannula. And that's why it's very essential that you image the left atrial appendage ostium clearly to rule out any clot in the LA ostium, which is the most common place for clot formation. Also, you can see some clot in the LV, and in these cases also, it's not an absolute contraindication for LVAD. Still, you can still the surgeon can go ahead with the LVAD, but the clot has to be removed. But this one, this infective endocarditis of any of the valve, this is perhaps the absolute contraindication for LVAD implant. So all the valves should be carefully examined before putting an LVAD. The degree of AR is very difficult to measure pre-bypass because with a failing heart, the LV end-diastolic pressure is very high with a low systemic pressure, with a low stroke volume. So the degree of AR will be underestimated. So ideally, we should increase the blood pressure with a vasopressor and assess the AR. And correction of AR is important because with the LVAD, the preload increases and secondary upregulation of the pump flow, it will be a futile cycle, which will affect the LVAD function. So if there is moderate, at least moderate to severe AR, the surgeon has to either change the valve, and if they change the valve, the choice is a tissue aortic valve, or sometimes they take a central coaptation stitch known as Park stitch, or sometimes they completely occlude the aortic valve. But completely occluding the aortic valve has the problem that there is more chance of a formation of the thrombus in the aortic root, and the LV cavity becomes a blind spot for thrombus formation. Any pathology in the ascending aorta, if there is gross calcification or like dilated ascending aorta, in this case, the surgeons have to be very careful, and it should be reported to the surgeon. And other valvular lesions, mitral regurgitation, whatever be the degree, even if it's severe, is usually doesn't pose any problem to the LVAD. Usually the MR improves after LVAD. Aortic stenosis, if more than mild, it may cause some problem, but still it's not a major problem. But mitral stenosis, anything more than moderate or at least moderate mitral stenosis, we should correct the mitral stenosis by putting a new valve. And moderate pulmonary regurgitation, at least moderate to severe PR, is not a problem for LVAD, but if the patient is requiring RVAD, then it's a problem if the patient has a moderate to severe PR. And the assessment of the LV, we need to see we need to check the baseline diameter, the left ventricular end diastolic diameter, because after LVAD it's supposed to come down. And if the LV cavity is small, then it's a problem. If there's more trabeculations, more small LV cavity, then there is more chance that inflow cannula can get stuck there and can cause obstruction. So the bigger the LV cavity is better for the LVAD inflow cannula to function. And if there is a large apical aneurysm in the LV, then that's a huge problem for the surgeons to put an LVAD. And if the apex has been thinned out, so LVAD is not possible. And left ventricular ejection fraction, baseline should be done to check, because sometimes after LVAD placement, the LV ejection fraction improves. And so baseline ejection fraction should be checked. And once the left ventricular ejection fraction improves or LV function improves after a few months or years of LVAD, sometimes the LVAD is decommissioned in few patients. So that's why it's important. LV diastolic function, usually you expect a grade 3 diastolic dysfunction, pre-bypass, and post LVAD, it improves. And sometimes there is some thrombus in the laminated thrombus in the LV apex, which is difficult to diagnose, and sometimes needing a contrast echocardiography or 3D echocardiography to rule out the clot. So these are the different red flag signs given by the AAC before LVAD placement. Now, immediate post bypass, what we should see. So upon LVAD activation, device name and initial pump speed should be mentioned in the imaging screen. So at what pump speed, what RPM you are getting the echo, so that should be mentioned. So first thing is the de-earring. De-earring is a crucial part for LVAD because we are always concerned about the RV function. If there is not adequate de-earring, the air in the RCA can cause acute severe dysfunction of the RV. So you should guide the surgeons by echocardiography for adequate de-earring. And to detect the unmasked PFO, so sometimes pre-bypass, the PFO is not detected, as I mentioned. So in post-bypass, with the LVAD flow, when the LVAD is sucking blood from LA to the LV, there is the LA pressure reduces. At that time, PFO may be more apparent. So you should always look for unmasked PFO, and at the same time, you can do the same maneuver, Valsalva, after post bypass to check if there is a PFO. RV dysfunction after LVAD, this is the most common problem after LVAD replacement. As you can see in the image, the RV is grossly dilated, hardly contracting. The intraventricular septum is deviated to the left. The intraatrial septum is deviated to the left. So there is severe RV dysfunction. So initially, what we do, we start with inotropes and sometimes nitric oxide. If they fail, and these candidates will go for a RVAD. So RV dysfunction post bypass, I usually do the fractional area change rather than anything, because after you open the pericardium, the TAPSA is not a reliable marker, but FAC is a good indicator for RV function. This image, I mean, the RV function is slightly better than the last patient. The intraventricular septum is midline. The RV is contracting, if not great, but decently. So this is acceptable. This patient will be managed by inotropes only. So aortic valve opening is a very important marker after to see the LV function. You have to put the LVAD in. So what we want, we want intermittent aortic valve opening. In this case, the aortic valve is not opening at all. That means the patient is completely dependent on the LVAD flow, and the LV has hardly has got any ejection. The problem in this case is that there is chance of aortic root thrombus, as I told. So at least some ejection some aortic valve opening should be there, and that should be intermittent. But in this case, aortic valve is opening very frequently. That's also should not happen. So it should be intermittent aortic valve opening. So again, after LVAD implant, you have to assess the AR, because the left ventricular end-diastolic pressure has reduced by the LVAD. So the AR, which was masked, now will be unmasked. So, but this time only two parameters can measure the AR, that is the vena contracta and the LVOT jet white by LVOT white. So if the vena contracta is more than 0.3 centimeter and the LVOT white is jet white by LVOT white is more than 46%, that denotes that the AR is at least moderate, and you should address the AR. You should correct the AR. And of note, that the air pressure uptime and aortic diastolic flow reversal obviously is not a reliable method post LVAD implant. The degree of tear also has to be assessed carefully, because the LVAD, what it does, it reduces the left ventricular end diastolic pressure, and also reduces the pulmonary artery pressure. So ideally, it should reduce the degree of TR, but at the same time, it is increasing the preload to the RV. So sometimes it exaggerates the TR. So the LVAD pump speed is very important. If the LVAD is sucking too hard, then and the LV cavity is particularly small, then the septum can be shifted to the left side and causing uh, altered geometry of the LV, altered geometry of the tricuspid valve annulus and leaflets, causing more tear. So by echo guidance, we have to optimize the TR. Now, pump speed optimization. In clinical practice, we do it in different way. So many centers want intermittent AV opening versus no opening, but in our center, we usually practice we want some ejection, some intermittent AV opening. So we keep the pump speed optimized like that. If we increase the RPM too high, then probably there will be no opening. So optimizing the pump speed RPM to allow intermittent aortic valve opening. Also, at the same time, we want the interventricular septum to be midline, not to be shifted in any side, and also allow some septal bounce to facilitate the RV contractility. This is particularly very, very important, because the RV is always compromised. And on the top, if the septal contractility or septal bounce is missed, then you can have the patient can have severe RV dysfunction. So it's always better to have some septal bounce. And at the same time, we can also optimize the RPM and speed of the LVAD to minimize the TR or MR at a given speed. If we increase the RPM, that will reduce the MR, and but if we too much increase the speed, then that will increase the TR again, and so that's again a problem. And pump speed should be optimized for acceptable mean blood pressure. Like anything, mean blood pressure, anything about 50 to 80 is acceptable, but around 60 to 70 is a good blood pressure for these patients. So now checking the inflow cannula. So inflow cannula should be checked very carefully, and usually we use a lot of non-standard views and different multiple views explained to see the inflow cannula, whether the inflow cannula is aligned at the midline towards the mitral valve. It should not incline to the septum or in the lateral wall. And when you give color, it should show laminar flow with no turbulence. And at the end, we take the velocity. It should be around 1 to 2 meter per second. Maximum velocity acceptable is 2 meter per second. But when the velocity exceeds more than 1.5 meter per second, we have to cautiously look for the high velocity. Then it has to be imaged in multiple angles, in multiple views, and to rule out any clot or any other problem, or any obstructions or kinking or anything. And so here in B, you can see the top velocity around 60, and with the nadir diastolic velocity around 40-45, which is absolutely normal. And it's usually regular when there is no obstruction. For outflow cannula, it's best seen in the mid-esophageal aortic, ascending aortic long axis view and short axis view, also in the mid-esophageal LV long axis view. And the color flow should demonstrate laminar flow again, and you should try to rule out any kink or obstruction, but this is very infrequently seen. Velocity more than 2 meters per second, it can suggest the obstruction of the outflow graft. And atheroma at the site of outflow tract can cause turbulent flow. Where maybe there is no kinking or no obstruction, but still, if there is gross atheroma, it can still cause outflow tract turbulence. So this is the outflow tract, you can see graft. And at the end, this may not be immediate complication, but maybe after a few hours or few days, the pericardial effusion significantly jeopardizes the LVAD function, so it can be ruled out by TOE. Now coming to few scenarios like LV suck down, like in this case in frame A, the pump speed was very high. We used it's a HVAD 2,400 RPM. The LV was completely sucked down because of the high speed and hypovolemia. And after correction of the hypovolemia and reducing the LVAD speed to 2,200, the LV cavity became normal. So LV thrombus is another problem. In case of LV thrombus, the aortic valve opening, aortic valve opening time, the aortic valve cusp separation time will be prolonged, and obviously with other features of increased in the inflow cannular velocity and other features. If the in case of pump failure of the LVAD, that can either happen due to thrombosis or mechanical malfunction. So what you can expect that LV will not be decompressed properly. In that case, there will be deviation of the interventricular septum to the right side. The functional MR will increase. Aortic valve will open in each cycle. You can see spontaneous echo contrast in LV and LA, and you will see regurgitant flow through both the inflow and outflow cannulas. So these are the features that the LVAD has mechanical malfunction or having a pump failure. Now, a few words about the RVAD. So once after implanting the LVAD with inotrope and nitric oxide, you can't optimize the RV function, then the only way is a RVAD. So RVAD is usually temporary, and here in the left side you can see the RA cannula, and here when you put color across the cannula, you can see continuous flow, and if you put a Doppler, you can see the continuous flow of the RVAD. And the winning of the RVAD, I think if we have time, we'll discuss about that. And the other thing I want to discuss, we have used this device a lot, Impala 5. Impala 5 denotes for the cardiac output. 5 means 5 liter per minute. So Impala 5 gives a very good cardiac output. It's again a temporary VAD, and FDA has advised to use it not more than 48 hours. But in our institution, we have used it for even 18 days. And some literature, some patients, they have used for 30 days. But without any problem. This is a really fantastic device, very safe device. So usually it is implanted either through the femoral artery or through the subclavian artery, and it goes into the from the aorta to the LV. You can see that the impella is coming from the aorta to the LV cavity, and the echocardiography wise, you have to make sure the distance from the aortic valve to the impella should not be more than 3.4 centimeters. So it should be anything between 3 to 3.5 centimeter. If you push it too far, then it will abate against the LV wall, and it will not function well. And if you take it out too much, then it will suck from the aorta and deliver in the aorta, so it will not work. So ideally, color flow in the impella should look like this. So it's sucking blood from the LV, and it's delivering into the ascending aorta. So this is ideally how impella should look like. And just one slide about the tandem heart. Once the impella has come, the use of tandem heart has been really reduced. So the tandem heart is also, again, temporary kind of VAD, and approach through femoral vein, and we need to do a intraarterial septal puncture to put the cannula in the LA, and it sucks blood from the LA. So, but I don't have any much practical experience about the tandem heart, and most of the days we are now using impella than tandem heart. I have just mentioned, just kept 2 slides about the troubleshooting of the VAD, and thank you very much. That ends my presentation.
That was a lovely presentation, Arup.
Thank you very much,
Very
sir.
nicely done with illustrations. Sriman Narayana, please start the discussion. Can I ask you one question?
Yes, sir. No problem.
Sir, please
There is
unmute your
one
mic, sir, please.
parameter called PAPI, that is pulmonary artery pulsatility index. Do you look into that in these patients pre-bypass? Is it a good predictor of RV failure in these patients?
No, I have in practice, we don't look into that. So we don't have any. Usually, we more focus on the fractional area change and the degree of tear, tricuspid annular dilatation, and
Okay. This is a parameter which is acronym is PAPI, that is pulmonary artery pulsatility index. It is mentioned that if it is less than 1.8, the chances of RV failure after LVAD is very high. The pulmonary artery systolic diastolic pressure difference divided by the RA pressure.
all right.
Pulmonary artery pulsatility index. That's what is mentioned, and we sometimes look into that in our center.
Okay.
Any questions from others? Do you use strain in these patients? Are we strain before bypass?
Yeah. RV strain seldom used. So, but that mostly used pre-bypass transthoracic echo, and sometimes the patients they are in the ITU waiting for the LVAD. In this patient, sometimes when we do TOE to rule out other things, then we do strain. If the strain is less than -14 of the wall, then the chance that patient will give trouble, it will be a stormy course post-op. They may need mechanical device. I mean, the RVAD later on.
Yes.
In our center, we use HeartMate 1. Impala device we are not, previously we were using. Now we have stopped using Impala device.
Yeah. What is your take on right-sided impala, Dr. Arup?
Yeah, so the right-sided impala is also there. So basically, it's actually a temporary RVAD. So the RVAD is basically very cumbersome because most of the RVAD we put percutaneously through the Protect Duo cannula. Because many a times what happens with the nitric oxide, the RV function settles, and we try to avoid the RVAD and try to extubate the patient and see. But many a times the patient don't do well, and that time they need RVAD. In that case, we do with the Protect Duo cannula, and it's a very big cannula, always giving us problem. And so in that case, right-sided impala, many centers have used right-sided impala with very good result,
Yeah. How is Protect Duo? Do you have personal experience with Protect Duo?
Yeah, the Protect Duo is a cannula which has got two port. I mean, so it one of the okay, opening is in the RA and directly crosses the tricuspid valve in the PA. So basically, it's a so sucking blood from the RA and delivering into the pulmonary artery. But it's a very big cannula in the neck, and most of the time there is oozing from the neck, and patient feels uncomfortable. Though we have mobilized the patient with Protect Duo and RVAD, but it's not very comfortable for the patient. It gives a lot of problem, and it cannot be kept for very long time. That's the problem.
Anyone wants to ask any questions? You covered most of the important points, how to tackle aortic regurgitation. You said that you use tissue valves or you put a
Well,
central stitch for that. So that's important point. Any questions from the participants? Is it clear? Everybody is happy with the presentation? I am very happy. It was quite good.
so when we have time, I just want to tell something. So when we have got problems with the LVAD, it's not only an echocardiographic diagnosis. So firstly, in a patient with LVAD with problems, so we should always look for the LVAD parameters. How is the, because I have used only third generation LVAD heart
Yeah, yeah.
age VAD. So there is no pulsatility index like the PI, which is given in HeartMath 2. So we don't have any pulsatility index, but
Yes.
it only gives about the RPM and power and flow. So it's very essential that we see those parameters and the clinical monitor the how is the mean blood pressure for if there is ejection or not. And that's very important. And at the same time, the lactate and metabolic acidosis if got a pulmonary artery catheter mixed venous oxygen saturation. At the same time, the patient clinically how is feeling, is patient cold or warm or these things making urine. So when after seeing all these things, then you should jump for the echo because uh, the echocardiographic diagnosis, the echocardiographic findings, same finding can happen in different scenario. So we should always correlate the clinical finding with the echocardiographic finding. Then only we can come to a diagnosis. Like in hypovolemia or RV dysfunction. The flow will be less. The RPM will be fixed. The RPM is always fixed. The power will be same. The flow will be less. Blood pressure will be less. So then it can have two diagnoses: hypovolemia or RV dysfunction. Then the CVP comes into act.
Correct.
Clinical CVP will be high. Lactic acidosis will be a lot of lactic acidosis. Then you do the echo and see what is the problem.
Yes, yes. I just wanted to ask you, this is not exactly related to TE. What is your strategy if the patient has a cardiac arrest during with LVAD?
The
The
cardiac
heart
arrest.
Yeah, do you do cardiac massage or not? Because there was some controversy in the last discussion. Somebody said cardiac massage should not be given, and the 2017 guidelines for management of LVADs, they said cardiac massage can be given.
Yeah. So what we do if patient has a cardiac arrest, then if this is
Yes.
absolutely unanticipated, then we give cardiac arrest, which is we are not expecting, but patient has got a cardiac arrest all of a sudden. Patient was
Yes.
well. In that case, we do give cardiac massage. But
Okay. Okay.
if the patient was declining slowly, and was anticipating that nothing is working, then probably we don't do anything. But a patient with LVAD, with severe arrhythmia, severe VF, severe VT, still I have seen many of the patients, they maintain the mean blood pressure quite well.
Yes.
In that case, we don't do anything. But if it drops the mean blood pressure, we give DC shock.
Yes. Yes. That's right.
Because the RV works as a passive chamber. It's not active chamber. So it is so even with
Yeah.
significant arrhythmia, many patients maintain the hemodynamics quite well.
Yeah.
Hi, sir. Pooja here, sir.
Yeah, Pooja, you tell
Morning.
me, you only raise this problem.
No, sir, I have read about this abdominal compressions and getting ready for fem bypass. That is what I have read. But the 2020 guidelines, ACLS says we have to do cardiac muscles. As yeah, the abdominal compression part was not written in it. That's what we discussed the other day.
Yeah,
And
it's not written there. Yes,
it's not written, but that's what we have read, that we have to start an abdominal compression and then we get ready for a fem bypass, because we cannot add the LV rupture. That is even more catastrophic. And Dr. Arup, very fantastic presentation. Can you please let us know about RAM study when we suspect LV thrombosis?
Yeah, so what happens that in LV thrombosis, can you hear me? I mean, my voice is echoing.
Yeah, we can hear you. We can hear you.
Yeah. So the thrombosis usually doesn't happen all of a sudden. It's usually a chronic process until a big thrombus from somewhere has occluded the inflow or the outflow cannula. So usually what happens, as the inflow cannula gets the thrombus or getting occluded, initially the inflow velocity will be very high, and gradually very high with a drop in the LVAD flow. But once it's almost fully occluded, then the velocity will be very low. Then the inflow cannula velocity will be very low. It will not be high. So and obviously it will drop the LVAD flow. But with significant occlusion in third generation HVAD, they can show a very high flow. They'll always flow more than 10 liters per minute. So it's a clinical, mostly occlusion of the inflow cannula is a clinical diagnosis. Initially, there will be drop in the flow with increase in the power, and as you increase the RPM, there will be further drop in the flow. It will not increase the LVAD flow, but if you put the PWD or CWD across the inflow cannula, the velocity will be increased. But once the inflow cannula is almost completely occluded, at that moment, the velocity across the inflow cannula will drop, and there will be severe turbulence.
Yes.
Thank you.
Thank you, Arup. Very nice presentation. If the patient arrests with LVAD, the first step is to check the LVAD function, whether it's performing normally or it's you have to sort out the pump-related problems, and then look into other issues like RV failure or hypovolemia, etc. Most of the patients who have arrhythmias during LVAD, sometimes they may not be recognized even by the patient because the pump flow is being maintained by the machine. But if the patient has symptoms of low cardiac output, we need to look into the functionality of the pump. I mean to say the LVAD, and then decide on the further course of action.
Usually, sir, nowadays with the third generation VADs,
yes.
machines are so good. I mean, with the machine malfunction, they start giving alarms, and very loud alarms. So they're really good.
Srimanarayana, final comments, because I don't think there are any other questions. I cannot see in the chat box. There's some compliments are there. Good presentation and nice presentation mentioned in the chat box, but there are no questions.
Yeah, Dr. Maity, a wonderful presentation.
Thank you.
And to sum up this one is pre-operatively you take the star where shunts, thrombus, aortic inefficiency, RV failure are to be ruled out previously well before you go for a LVAD implantation, and post-operatively look for the same. There is any.
Yeah.
Yes.
And thank you everyone for participating. Have a Sunday.
Thank you so much. We'll see you tomorrow for the cardiac anesthesia update. Thank you so much. Thank you, Arup. We'll see you again next week.
Next week, yeah. Surely.
Thank you so much.
Thank you very much. Thank you, everyone. Thank you, sir.